everyone, and welcome. My name is Elizabeth, and I'm with ACRC Global. I work closely with intended parents exploring surrogacy, egg donation, IVF, and other family building options. Today's webinar is focusing on choosing the right gestational carrier, a doctor's guide to a successful surrogacy journey. And we'll be discussing when surrogacy may be the right option, what to look for in a gestational carrier, the medical screening process, and how intended parents can best prepare for a successful surrogacy journey. We're so happy to have Dr. Susan Nassab, Medical Director of Celanova Fertility, with us today. Dr. Nassab, thank you so much for joining us today.
Thank you so much for having me.
Yeah. All right. And before we begin today's discussion, I'd also like to briefly introduce ACRC Global. We originally founded in 2015, and we are headquartered in Irvine, California. Over the past decade, we've helped more than 1,300 families around the world build their families through surrogacy, egg donation, IVF support, and other assisted reproductive technologies. Our core services include surrogacy programs, egg donor matching, embryo transportation, IVF concierge services, and international family building support. We work closely with fertility clinics and doctors like Dr. Nassab, attorneys, insurance specialists, and case management teams to help intended parents navigate every stage of this journey. So whether you're just beginning to explore options or you're ready to just move forward with treatments, our goal is to provide you with guidance, resources, and all the support throughout the process. All right, and then for our intended parents who may eventually explore egg donation options, we do have our own egg donor database. Right now, we currently have more than 200 egg donor profiles that are available. Parents can filter and search based on ethnicity, blood type, as you can see on the screen. That's what it looks like on our website. So you can even filter by height. And each profile will include detailed background information, childhood photos, and in many cases, video introductions. All donors complete medical history reviews and genetic carrier screening before becoming available for matching. So many of our intended parents do begin IVF using their own eggs, while we do also have others who eventually explore egg donor options, and we're here to support both pathways. All right, and now I'd like to officially introduce today's speaker. So Dr. Nassab, thank you again for being here. And would you mind briefly, introducing yourself and just sharing a little bit about your background and your work with patients experiencing PMOS and, different fertility challenges?
Sure. Thank you again for having me. I'm Dr. Susan Nassab. I am a board-certified OBGYN and fellowship-trained reproductive endocrinology and infertility specialist. I'm the medical director at Celanova Fertility, which is the part of a big fertility network in the country named IV. Obviously, we have a full scope of fertility evaluation from at any age that people wanted to conceive. Obviously, we don't have any biases to sexual orientation, cultural background, and also I'm highly invested in ovarian rejuvenation and oncofertility. So obviously we are treating all type of fertility diseases and offering treatments such as IUI, IVF, time intercourse, and we also have a very exciting program add-on for the hormone management on their Empower program for menopause, perimenopause. More specifically about the surrogacy journey, we have a great third-party program based in San Diego, partnered with San Diego Fertility Center, who has years of experience working with third-party. Our main office is in Rancho Santa Margarita, and hopefully we're going to expand to Corona next year. Obviously, we are offering multiple avenues for third-party intended parents who are willing to use a gestational carrier for medical and non-medical reasons, and inside the country and outside the country. The couples or the individuals who require donor egg, donor sperm, same-sex couples. I'm also highly invested in transgender population that most of them, they need some sort of third-party program. We are working with multiple agencies, and I'm very glad that I'm working with ACRC as well. And throughout the webinar, I will explain the process of a screening going through. But yes, that's who I am. I have a great team of more than 90 staff sitting behind and helping us for financial authorization, insurance authorization, and we also provide multiple financial support and working with a lot of outside collaborators in terms of the mental health, holistic coaching. Yes, and I'm here to answer any question you have.
Awesome. Well, thank you so much for that. And before we do officially jump into the discussion, I'd also like to share a special opportunity for everyone joining today. On the screen, we have a QR code right now. You can scan it to schedule a complimentary consultation with the ACRC team. Whether you're looking for IVF, egg donation, surrogacy, fertility preservation, or simply looking for guidance for the next steps, we'd love to discuss your individual situation and answer any questions that you have. Feel free to leave any questions throughout this Q&A through the chat. We'll also have a little part at the end where we'll just leave 4 questions. And I'll also share some information on how you can get in touch with Dr. Nasab's team as well at the end. But right now, let's go ahead and officially get started. All right, so let's start with one of the most common questions intended parents ask. Dr. Nasab, who is a good candidate for gestational surrogacy? Could you explain the medical and, maybe non-medical reasons some may need a gestational carrier and whether intended parents should begin considering this option?
Excellent question. And it's always a first question. Good candidate versus candidate is a difference. So we have an ASRM guideline from the American Society of Reproductive Medicine that there is a guideline in terms of what age, what BMI, what medical in general from the age standpoint between 21 to 45-year-old, at least 1 uncomplicated delivery in the past, no more than 5 vaginal delivery or 3 C-section, obviously being healthy. And there's so many criteria, but these are the few big ones. Obviously, not everyone at this age range are the same from the medical and health standpoint. We are very strict in selecting and technically clearing our surrogates. So in terms of medical and non-medical indications for intended parents, non-medical indications can be anything, right? I have intended parents because the workflow, they're so busy, there are athletes, they're traveling too much. The dynamic of the family is not appropriate for the mother to go through 9 months of pregnancy. And this is technically, we don't ask them why you are choosing a surrogate. However, if you look at the dynamic of the family, if there's anything that we can help with, and also based on my experience, Elizabeth, sitting here, and I'm sure you have that experience too, as soon as the IPs start talking about their journey and future fertility wishes, I know which candidate is good for them and fit for them or not. So non-medical indications, it's very important that we both, as a physician and also as an agency, look at the dynamic of the family, cultural background, and what environment, because it's very important that the IP and the surrogates, they have a great relationship. Medical indications are so many. If a woman has medical contraindication to carry the pregnancy, which I have a lot of cases get referred to me, they have cardiac problems, stroke problem, they have so many diseases that pregnancy is detrimental for them. And also anatomical issue. A lot of cases, unfortunately, they go through cancer, they lose their uteruses for even non-cancerous issues such as fibroid, they do surgeries, they have, delivery and, they lose their uterus because of bleeding and so many reasons. So we assess the intended parent for medical and non-medical indications. And obviously, same-sex couple who are male or gay couples, obviously they need the gestational surrogate. I have so many transgenders that they have, they froze their eggs in the past, but at some point they don't want to carry the pregnancy. There are, issues with them carrying the pregnancy where they have done hysterectomy. So these are the indications. And when should intended parent consider surrogate? Very good question. And I always tell them as soon as possible. This is a time-consuming process. This is not just you go and do online shopping. You have to do your due diligence. Look at which doctor and clinic you want to go to, look at the success rate, and look at the agencies. Go for the legal advice, consultation, do your due diligence. Yes, I, as a doctor, no matter who is gonna you choose and send it to me, I will take care of it. Stay assured that I'm sure any board certified REIs or OBGYNs, they follow the guideline. We are not actually deviate from the guidelines. So be sure that we will choose the best and healthiest surrogate for you. And agency is the same. They have some guidelines that they have to go through it, but it's better to start as soon as possible, because I know that you want to, as intended parents, want to have a baby like yesterday, but we are making a human and we want to grow that human being in a safe environment, and that's why we are here today.
Right. Yeah, thank you for sharing that. And yeah, similarly, we also follow the ASRM guidelines too, for, the intake process. I'm also glad that you brought up, the non-medical reasons to match with, a surrogate, because I feel like that is very important, just the relationship that you want to have with your gestational carrier throughout, the 9 months or longer, actually, that you'll be communicating with her. So thank you for bringing that up. All right, let's go to question 2. All right, so once a patient decides to pursue surrogacy, what happens next from the medical side? And could you walk us through how intended parents are evaluated and prepared for treatment, including, fertility testing, embryo requirements, the FDA and ASRM guidelines that we talked about? Just go into a little more detail.
Yes, absolutely. It's very important when we talk about, GC, from now on I call GC, it means
Yeah.
gestational carrier. Everyone is thinking that we should just evaluate GC, go into a test, make them pregnant. Don't forget that you, as an IP, you are actually the main parents. So the FDA require you also to get evaluated. When I ask the parents to come in for the exam, they're like, why are you examining me? I mean, I don't want to get pregnant. Yes, but per FDA and ASRM guideline, we have to evaluate the intended parents, making sure they are eligible to become a parent. So in terms of the age, it's very variable. ASRM and also FDA, they don't have a set number of the age. Each clinic, they have their own ethical committee. So we'll look at the couple as a whole case, making sure that child that we are helping to bring this ward has a caregiver technically and a parent. So definitely you will go through the medical evaluation. You're not going to get rejected because of the medical background, stay assured, but we have to make sure, again, psychologically and physically you are able to become a parent. The psychological part is not my job. We absolutely send you for psych eval, and they have their own criteria. Again, making sure you're in a stable psychological status to be able to become a parent. But FDA also asks us to do a physical exam. So normally the IP or intended parents are coming to the clinic. We do FDA exam, which is technically heart, lung, genital exam, and the full evaluation. There is a more than 70 questionnaires about their background, drug use, alcohol use, history of sexual, transmitted disease. FDA is very strict about the infectious disease. Yes, you as IP needs also to do the testing. It's very important. So we also go through that. So it's a questionnaire, it's a visit to the doctor, and also a physical exam, and also lab, which is mainly this STD or sexual transmitted disease. These are the requirements from the IP. And after we technically clear them from the medical standpoint, they go back to the agency, and I'm sure that you have the process that you want to explain. And a part of that, again, is the mental clearance. In terms of the embryo requirement, again, each lab, each IVF lab has their own rules and regulations. Some labs, again, I'm talking more broad, some labs might not accept the eggs and embryo from the outside lab. We accept the eggs and embryo from different places, but of course, they have to pass the exam. There is a year difference between when the embryo were made, which lab the embryo were made. Again, just because I had this experience, and we can go through it, just the 1 hour webinar. The patients, I do accept it, yes. And then when they signed up to the transport team, and we'll look at multiple criteria: when the embryo was made, in which environment, is it in one canister or multiple canister together, can we thaw them, meaning taking them out of the freezer, the way that it was taught before, how many years it was passed. So these are all the requirements if we want to accept the embryo or eggs from outsiders. Agencies that they provide donor egg or donor sperms, they have also passed these FDA exams. So when we are getting from a trusted agency, we know they passed it. We just check the paperwork. In terms of a lot of them, they asking me they have to be tested or not, meaning PGT tested, euploid, yes or not. They don't have to be tested. Again, all of these GCs are young. They technically are healthy, no medical contraindication to become pregnant with twins or higher order. But we also have a guidelines of the number of the embryos to put in. Again, that's something that keep asking. Just because it's a GC, you cannot ask for twin pregnancy. There is a guideline. You cannot put more than one embryo if it's tested and normal, no matter what is the age of the GCs and the previous miscarriage history. However, if it's not tested, you, based on the age of the surrogate, we can, and also we can talk with the IP if we can put two. At the end of the day, the GC has to accept it. Again, there is a very strict guidelines of how many embryos we can put into the uterus as well.
Yeah. And yeah, going back to the psychological screening, once you are like officially matched with a surrogate, that's one of the first processes that we do is we do a psychological screening of, both you, the intended parents, and the surrogates before moving forward with anything else. So yeah, thank you for sharing that information. And we can go on to question 3. All right, so choosing the right gestational carrier is obviously one of the most important parts of the journey. I think we've reviewed this a little bit, but from a physician's perspective, like what qualities and medical qualifications make an ideal gestational carrier? I think one thing that you can highlight more, Dr. Nassab, is are there any common misconceptions about those, who can qualify?
Yes, absolutely. Again, there is some criteria. For example, the age per ASRM guideline, it has to be between 21 to 45. However, we know above 35 consider advanced maternal age, for example. So I make more, take a close look of the surrogate. If it's, again, I'm not going to say no to anyone above 35 or 40. Technically, it's under guideline of ASRM, but we have to be more cautious when the age goes higher. We look at the different backgrounds. Again, weight is a big deal, so we want to be a BMI below 30, but again above 30 to 35, and the ASRM is saying that by cautious, if the patient or GC has some medical history, not contraindication, medical history, we look at as a whole patient. We closely work with the maternal fetal medicine or high risk OB doctor if surrogates technically fall under the category of ASRM guideline. However, there is some, not red flags, there are some questions about the medical qualification. I have no hesitation to send the GC to the high-risk OB and get another set of eye looking at the background. Hypertension, diabetes, weight, thyroid disorder. But in general, the qualification per ASRM is age between 21 to 45, one uncomplicated delivery in the past, no more than 5 vaginal delivery, 3 C-section. Again, each C-section is different. I might find a GC with 1 C-section but has a, very bad scar, and I say no, and I find someone with really like 2 or 3 C-section, perfect. So again, it's really, you should trust the decision of your doctor of this medical qualification. Pregnancy history we talked about. Misconception, there are a lot. They think positive and negative. Positive is that, okay, just because she delivered 4 in the past, she's gonna go get pregnant right away. Again, with the normal embryo, with the best uterus, which is normally our GCs, the chance of implantation in the first round is about 60 to 65, and the best case scenario 70. If anyone is giving you 80, 90, 30, I'm telling you from this webinar, it's a lie. It's very high expectation. I tell the patients, like, look, this is the best type of pregnancy, normal embryo in a perfect uterus, but in the first round, it might be between 65 to 70. Second round is about like 80%. That's a big misconception. I have had patients that, for example, the uterus was not competent, they keep having a miscarriage. Of course, this is an expensive, journey. They spent time and money on a surrogate, and when the first transfer didn't happen, they were devastated. They were like, they lost their mind. Again, most of the GCs on the first round, they get pregnant, so don't get like panic, but it might happen. So that's one of the best misconceptions. The other big misconception is that if a surrogate miscarry, they have to change the surrogate. No. When a surrogate miscarry, I evaluate them and I see what was the reason of the miscarriage. I look at them so like other patients. Yes, of course, if a surrogate keep having a miscarriage, probably is going to get disqualified for becoming a surrogate again. But just having one miscarriage, that does not mean that you get panicked and start calling the agency and the doctors and trying to change your GC. Other misconception is that in the other way is that the IP can dictate the treatment. This is very, very sensitive subject. Again, you have a lot of word to say and right to say, but you don't have autonomy on someone else's body. That's why when Elizabeth was talking about legal paperwork, I highly recommend, before going through this journey, read and ask questions. That's why the agency for. Ask multiple questions. What's going to happen if you want to do this? Can the GC accept this or not? So that is preventing having a lot of conflict and issues in the future, getting legals, get involved, and also make the journey very friendly and nicely, because that is, although the GC is not that biological mother, but it's carrying your child for 9 months, and the status and mental and physical health of that GC is going to affect your future child. So I think that's the big three misconception that I see all the time in the practice.
Yeah, I'm glad you brought up especially like the embryo transfer success rate. That is one that, yeah, like Dr. Nisab said, if it's over like 70%, someone tells you, then that's not that's not accurate. Um, and yeah, I've gotten that. I've had like intended parents say, "Oh, someone said like 80%." I'm like, I don't think that's accurate. You might need to double check that. Yeah.
I heard from other one, oh, this is a surrogate. Why shouldn't they get pregnant? I heard like the expectation is actually 100%. Let's put it that
Yeah.
way.
We get that sometimes, and you have to explain it, and they'll be like, okay, you can talk to the doctor, right, to give you further details on
Yes,
exactly how that works.
yes.
All right. So let's go question 4. So let's talk about how intended parents and gestational carriers actually come together. So Dr. Nasab, could you first explain the medical and psychological screening that every gestational carrier completes? And then after that, I'd love to, share how the process works. I can go into a bit more details from
Yes.
ACRC side as well.
Yes, the first one, agency versus non-GC. Again, the agencies, they have the guidelines, they get the candidate, they put them through the first process of screening, intake, eligibility criteria, psych eval, legal eval. And then when it matched with the IP, which I let Elizabeth talk about the matching process, we don't get involved too much of the matching process. We see the IP and we listen to them, see what are the indications and why they want to have a GC and what are their wishes. And when they get matched through the agency with the GC, and then I see the GC and I explain to you, both of them, they go to the FDA screening, both of them, they go through the medical screening, and both of them, they go through the lab screening. So that is technically the process from our side. The agency side is much more detailed, which Elizabeth is going to explain to you about the matching process. That
Yeah.
is like for us is the easiest way. When a patient is sitting here, or a couple is say, okay, Dr. Nassab, I have someone in my family, my friend, best friend is, for example, is want to be a GC. The process is exactly the same. Your GC, even when you are, so another misconception is that when family and friends, they can bypass. You cannot bypass any of these steps. Same thing as a known GC. We also work with different agencies. We refer them to one of the agency, and the same steps that the anonymous candidate go through the process, that known GC will go through the process. So that means that your friends or family needs to be cooperative with the FDA exam, lab exam, legal paperwork. And I'm telling you from this webinar, that happens with the donor eggs as well, the candidate, anonymous versus directed donor egg person. And when the patients, they look at the multiple steps of a screening, they say, okay, you know what, we're going to use the agency one. So again, if we can do that, and we are doing that, but your person or family or friends has to be extremely cooperative to go through all of these guidelines, and there is no way that we can kind of deviate from these guidelines. Medical, psychological, and background screening, we just talked about it, that we go over that. I take care of the medical part, agency take care of the background screening, and the psych eval does the psych, doctor. We also at our center, we have also third party program team that they also have their own screening criteria. Let's say you as an IP, you match with a GC with ACRC agency. Okay, Dr. Nassab, we are ready. We are matched. Now go through the process. We also have another layer of screening that I understand for the patient's standpoint, why it takes so much time, why you go through this. The why is that it's for you, it's for your safety and for your outcome. A lot of cheesecake model sleep through, I might not find something very important. Elizabeth will not pick it, my team might pick it, or something like that. So it's always good, 3-4 different teams will look at your GC and look at your cases. So don't get disappointed with this waiting time. This is actually better for you. I'm sure that Elizabeth, you have seen different agents. The reason is that we work with only few agencies, not everyone. Again, not everyone doing their homework in a good way. You don't want to like just submit your OB record to the AI system in 2 seconds. They evaluate for you. A trained person needs to sit down and look at page by page of their medical record, OB history. Medical part, OB history is very, very important. So if someone has 2 or 3 previous delivery and you're so proud that that GC had a delivery, we both need to look at all the records, delivery records, hospital records, complications, postpartum. So these are the things that we are looking from the medical standpoint. Psych has a separate team, and the background screening I just explained, the third party program and the agency. And when they are matched, when the GC is ready to go, then there is another steps of technically preparation.
Yeah, I completely agree with if, like a lot of intended parents, especially when we say like now we're sending the medical records to your doctor, it's probably going to take a couple weeks, maybe even longer. There are like, oh, why does it need to take that long? But, to sit down through all the medical records and, have someone personally review it, it does take that long, and, it's definitely beneficial. And yeah, I can go into a little detail on our end as an agency, how we also screen our surrogates. So, we do a first interview with the surrogates, make sure they know what's expected throughout the journey. Then we do a second interview with their spouse or a close family member, but we do personally want someone who will be close to them, like supporting throughout the journey, both mentally and physically there. We also do a background check. If she does have a spouse, they will also undergo a background check. We also do a drug panel. And then we do have an in-house medical records team that specifically goes to her previous OBGYN hospitals, collects her delivery records, and reviews them to make sure there was no major complications in her previous deliveries. And another thing that can also be in those records is if she had any mental health issues. And that, can also be something that's very important for us to review before considering her ready to match. But yeah, once they are ready to match, then that's when we schedule an official match meeting with the surrogate. So once you find a surrogate you're very interested in as an intended parent, we set up a match meeting. It's typically a Zoom meeting where you're able to talk with her directly, ask any questions. She can also ask any questions, and I'd say this meeting is very important to make sure both the relationships are clear, right? On how often you want to communicate with each other, just get a feel for each other before the journey officially begins. And then once the match meeting is complete, and if you guys decide to move forward with the match, then that's when we'll directly connect with your clinic, or like Selenova Fertility, for example. We'll send over the medical records for them to also personally review, right? Just to have someone else review it. And then once they've officially reviewed it and said it's good to go, then that's when we organize for the official medical screening. And also during that process, like Dr. Nassab said, the psychological evaluation that'll be completed as well as the medical records are being reviewed. So that's how it looks on our end as well. Um, yeah, so let's go with the fifth question now. All right, so now that we've talked a bit about the matching process, I'd like to walk everyone through what happens next. From ACRC's perspective, I'll kind of give a quick overview about the surrogacy journey, from the initial consultation through the delivery. So for us, what the surrogacy journey looks like, I'll go first, Dr. Nassab, on kind of what it looks like from our end, and then you can go into a lot more details. Um, so yeah, like I said, once you are officially matched, then that's when we'll send over the records to the psychological evaluation, and then your agency will schedule with your clinic the official medical screening. Once that is complete, then that's when we move into the legal process. And like Dr. Nassab said, it's important you can start right away, like right now, consulting with attorneys for this, and we can help you as well if you'd like recommendations on certain attorneys. We just recommend someone who's familiar with surrogacy. And you can have a consultation with them, but you and the surrogate will be given an attorney for the legal process. And that typically takes about 2 months on average for the legal process. It can take longer or shorter, just depending on if there's more back and forth, but that's our estimate. And then once the legal process is complete, then that's when we will officially set up for the medical or the embryo transfer. So that's when the surrogate will go back to your clinic or Selenova Fertility and do the official embryo transfer. So from match to embryo transfer, we typically, on average, say it's about 4 months. Again, it does depend on, it can be shorter than that, it can be later than that. That's kind of just our average. And yeah, Dr. Nassab can go into a little more details on specifically what the journey might look like for the surrogate throughout.
Excellent. So we just talked about the hard part, which is the matching, screening. Now, legal part and psych part is done. Now, let's say the surrogate is ready. Obviously, we need to have the embryo first. If you made your embryo in our center, that's easy. If you have made the embryo somewhere else, we request that embryo to be shipped and accepted. It's very not good. I start the process with your surrogate, and then I say, sorry, I cannot accept your embryo. So we can do the evaluation at the same time, but again, based on my experience, it's better to take care of your embryos first. Now, let's say your embryo is here, your surrogate is ready. A lot of my surrogates are out of states. That's not a problem at all. That's questions that I get asked all the time. We ask them to come here for obviously the FDA exam and one-time uterine evaluation. We have to make sure the uterus is cleaned and cleared, either by saline infusion ultrasound, which is putting a water in the uterus and do a 3D scan, or more closely, which is the gold standard under anesthesia, and I perform all of the reproductive surgery here at Selenova, 10 minutes anesthesia will look at the uterus, making sure it's clean, come out. Sometimes the surrogates wants to do this in their home state. Again, that's between the surrogates and IP and the agency. Obviously, I as a physician, when I want to put an embryo into uterus, I prefer to take everything by myself and accept the responsibility. But that is the process. Obviously, the surrogate will go through some lab work, ultrasound, and uterine cavity evaluation. This is after they pass the FDA screening, lab screening, sexual transmitted disease screening. Perfect. Then when it's actual time for the embryo transfer start, it's about 3 weeks. 2 weeks normally is hormone administration. We make the lining thick. The surrogates come 2 to 3 times to the ultrasound unit. We check the lining. Again, sometimes they start in another state and come here. I highly recommend at least for that 2 weeks, you be here. We check the ultrasound and lining and lab by ourselves. We also do a lot of adjuvant therapy if you need it. Regular transfer cycle is mainly medicated, meaning we give them some hormones, which is technically estrogen pills and patch, check the lining. It's about 2 weeks. Sometimes we might go to week 3. When the lining is ready, then we give the progesterone shots, which is normally 6 days. And after that, we put the embryo in. During that 2 weeks, it's important that the GC cooperate with us. No sexual intercourse, no traveling. If they have fever or infection or antibiotic, let us know. We have very low threshold to cancel the cycle. We want to make sure the cycle is looking perfect. A lot of anxiety IP they have when specifically they are not in town and they think that we just transfer. Stay assured we don't do transfer unless the GC is appropriately ready. Let's say they pass that 3 weeks of stimulation and progesterone. The transfer is pretty easy. It does not require any anesthesia. With a very soft catheter, like an IUI catheter under ultrasound, we put the embryo in. 10 days later, we're doing the first pregnancy test. It has to be by blood. Again, please do not ask your GC to get like just a urine stick. You have to get the blood by the level. Normally, we check for 3 times, and when the pregnancy is confirmed, we do the first OB ultrasound around 5 to 6 weeks to confirm the pregnancy, and then do weekly ultrasound. Around 7 weeks, we expect to see the heartbeat. As soon as we see the heartbeat, and that's a major milestone. So milestone number 1 is get to the transfer time. Milestone number 2 is 10 days after the embryo transfer. When we see the positive pregnancy test, that means that she is pregnant. Milestone number 3 is around 5 to 6 weeks of gestation when we confirm the location of the pregnancy. Sometimes it can be ectopic, and the number of the sacs. Milestone number 4, which is extremely important, is the viability when we determine the heartbeat. When we see the heartbeat, normally I tell the agency and also the GC and IP go for for an OBGYN established care. We normally see them weekly until 10 weeks. And 10 weeks for us is a big graduation day, meaning that we say, okay, we took care of you. Now you have a viable pregnancy. Go to your OBGYN. That does not mean that we lose the relationship with the GC or the agency. But normally when you graduate from our care, you go under OBGYN care. After that, anything happens is under your OBGYN care. I have a lot of surrogates actually that come back to me for the second surrogacy, journey. Highly recommend you be in touch with us postpartum. If any of the GC are listening to this webinar and you're getting ready for your second journey, it's very important you get ready in between the pregnancy, take care of yourself, medical and health. But yes, these are the major milestones. The legal and logistical overview, again, we as a physician, we don't get involved that much. We trust our agencies and we trust our legals, but that's how it works.
Yeah, thank you for going into a little more detail on from your guys' end how that journey looks. And yeah, it can be really fun when surrogates like they want to after their first journey do it again. They want to stick with the clinic. It's just really nice because everyone already knows each other from the first journey, so that can be really fun. All right, so let's go to question 6. Well, I guess it's not really a question, but many of today's attendees might be joining us from outside of the United States. So I'd like to share some key things that international intended parents should keep in mind throughout the journey. including communication with the team and travel planning and all that. So that is one of the major things that ACRC, helps with is the coordination and ensuring that everything is coordinated even after the delivery. We have a specific team that will help the intended parents, especially if they're international, focus on how, to collect all the right documents before traveling back to wherever, what country they would like to travel back to. And then we do also, I personally, for a lot of international intended parents, California IVF clinics are pretty recommended just because of a lot more leniency for international intended parents in terms of the legal process. So if you are an international intended parent, we highly recommend, having a consultation with Celanova and going through that process with them. And those are kind of the main tips that we have, but I think especially for international intended parents, it's good to have, an agency to help you guide through this process and also have a doctor like Dr. Nasab who has experience as well with international intended parents. Dr. Nasab, do you have any, kind of recommendations for international intended parents as well?
Sure. As you know, more than 60 to 70% of our third-party cases are international. And the reason of that is so many things. Each country, they have their own rules and restrictions regarding the usage of third-party program. And as you mentioned, California, also in the United States, each states they have their own different rules
Yeah.
and regulation. California is one of the states that have a very appropriate legal process to offering to the international IPs. Again, having a lovely and experienced agency and also third party program team in my clinic, it makes my life way easier to dealing with international IPs. From the medical standpoints, there is no difference between national and international. IPs from international also needs to come here and do their FDA exam. They have to come to do their test. We talk and communicate with some of the fertility clinics and OBGYNs in their home country if they also pass the FDA exam, meaning that they made embryo. I just had a IP from Taiwan. They had an embryo. They made the embryo. Again, some clinics they just don't want to go through process of the headaches and approval and FDA and screening. We really tried international patient because I understand that I had an IP that was like on the Zoom. It was like it's impossible, Dr. Nassau, to travel all the way to US and do all this process. And I have done all of this in my country. Again, we will help them. That's why in the very first slide I asked to start earlier because there are so many rules, believe me or not, we have to follow and we cannot deviate the guidelines. So for the international, again, we have a huge international teams talking and speaking in multiple languages. I speak Farsi and English. My team are fluent in Chinese, Japanese, Spanish, Korean, and also multiple European languages, French, Deutsch. So we can help you for that. And also get a consultation with us because it's important to see the IP on the other side of the world. If you wanted to travel to come here, welcome. I have a lot of IPs at the time of transfer or at the time of delivery. They travel here, but sometimes they can't. From the travel and birth document, we highly rely on our agencies.
Yeah, like Dr. Nassab said, not all clinics will, accept the embryos or gametes that are transported from outside the US. So that's very cool that you guys do that. And yeah, we try as well. That's why we like have one of our offices in Japan. We specifically have it for like sending FDA testing kits to our IPs and, the clinics nearby so they can have that opportunity, if they don't have the opportunity to come in person, to complete that abroad. And then we can help with the transportation of the gametes as well. So yeah, that's a little bit about, international intended parents. But I'd say me and Dr. Nassab, we both very much welcome international intended parents. And yeah, our team as well, we have, English, Spanish, Korean, Chinese, Japanese, French as well. So we have a lot of languages too that for any, international intended parents. All right. So let's go to number 7. So before we wrap up, I'd love to hear, kind of from both of us, Dr. Nassab, based on your medical experience, what are some of the most common mistakes? Or we went a little bit into misconceptions, but if you have any more, you could share that you see from your end.
That's my favorite question. As a
It is.
professional.
It's the juiciest, right?
No, this is we need to advocate for our patients and be very transparent, not sugarcoating. So when the most common mistake is that, and again, unfortunately, that's the process. This is an expensive process. When IPs wants to choose a GC and agency, the very first thing they'll look at the prices and packages, and they choose based on the prices. Yes, we of course, the financial part is a big part, but do your research. The biggest mistake that you can do is find a GC or agency that does not do their homework in a good way. They do mistake at the screening part, at the intake part. Do your research about which doctor and clinic you want to do. It's not just like I come and I get the embryo out of the freezer, put in the uterus. A lot of part and issues can be prevented by your trusted medical team and agency. Ask the questions. Again, the most common mistake is that choose your services based on the price and choose your clinic or choose your agency just you know, by the look, by the taste, by the chat GPT, by, just some, because an influencer or a TikTok putting on the social media, you just love it. Please do your research. Please look at the success rate on the clinic. Look how much experience they have with the GC, which agency they are working with, what are their qualifications. Again, I need to advocate for you. I have seen some patients, they go to other countries, which I'm not going to name it, with other agency, which I'm not going to name it. And unfortunately, they went through a lot of problem legal wise, health wise with the surrogate. This is your children and you want to put it in a right place and grow it correctly. You put in the GC, and if you are not choosing your doctor who is evaluating your GC from head to toe, and if you're not choosing a correct agency, they just accept anyone on the street to be a GC, you are putting your child in danger. You don't want to go through a lot of fight and go to the court and the legal process. So this is the biggest mistake. Do your homework right now. Other big mistake is time. Don't rush it. The very first thing that everyone is, I see that Elizabeth is saying, oh, I want to do it as soon as possible, get the embryo as soon as possible. They call the clinic millions of times, clear this GC. They get mad at me when I disqualify them. They get mad at me when they are asking like, check this, check that. No, you should actually be happy. Because again, this is not just online shopping. And I say this one in a sarcastic way, but I really mean it. There's no refund. There's no exchange. There's no return. This is your child. When you made it and I put into the uterus, it's going to continue to grow. And that's your child for the rest of your life. So put in your mind, there's no return, there's no exchange. So don't do these mistakes. And tips for a smoother journey. As I said, when you do your homework in the beginning, that's exactly when you're prepping for exam. Then you love it. When you have an appropriate GC case, when you see your outcome, when you go to the ultrasound, visit, you see the heartbeat of your child, when you have a great relationship with your agency, they come for your delivery, they come to the hospital, and you hold your baby and going out, we want you to say, okay, I appreciate you, Dr. So-and-so. I appreciate you, agency so-and-so, to give me this child. And that's going to be the best marketing, word of mouth. And also, you come for your second child to us. That is the best, advice I can give. If I want to use GC for myself, I do the same thing. And again, because we are sitting behind the scene and look for all these issues, again, the last tip that I can give it to you, do your homework, do the research, look at the people, read the credential, read the experience and success rate of each agency, and also read about the clinics.
Yeah, thank you for sharing that. And yeah, I completely agree with basically everything you said. I think especially yeah with agencies, it's very important. And I tell because I know intended parents when they talk to us, they're going to be looking at other agencies, right? So I want to let them know that one of the most important things is to check the agencies, like their pre-qualifications, what they do to qualify a surrogate. Not all agencies do have a like in-house medical records team. So it's important to make sure what process at because each agency can be different, to directly ask those questions. So then it's more likely that the GC will pass the medical screening and review. But yeah, and I know a lot of times it is unfortunate maybe when the surrogate might not pass that. But like you said, in a way, it can be a blessing to, like make sure that it's for your baby, right? You want to make sure that you're taking the necessary steps, and that you have the right, surrogate for your journey. So I completely, yeah, agree with everything that you've said about that. And yeah, another thing too, I would recommend is looking at like the cost sheet breakdowns. Not all like agencies, and I've seen clinics too, are like as specific with what cost each. So that if you rent an agency where theirs are pretty vague, I would not recommend them. Just to, find an agency or clinic that's very transparent about cost too, and upfront. Yeah. All right. So let's go into this is, yeah, I think our last question. So finally, we'd love to share, why Celeno Fertility and ACRC Global have chosen to work so closely together. So Dr. Nassab, from your perspective, what makes this, collaborative care model valuable for patients and intended parents?
I think experience and workflow. Again, we just talked about how the IP and GC can communicate with us or with you. Remember that from the clinic and agency, we also do millions of communication emails back and forth. That's also important. That we in Salanova, technically, which is the part of the IV Fertility Network, and at San Diego Fertility Center, who's my partner clinic, we have extensive experience working with a third party program. And also being in California, again, because we have a lot of patients, they travel to California for third party programs. We know the entire journey. And why with ACRC? Because of the communication, experience, workflow, and being organized. If I, as a doctor, send my records, like, because it's not always agency refer to us, we refer to agency too. As I mentioned in the beginning, I have a lot of oncofertility cases that because of the cancer status, they immediately freeze embryo and eggs, go through the surgery journey, and then post-op, most of them, they need a surrogate. We also send it. So again, I think the workflow, being organized, being responsive, and it's the most important part. Again, we have guidelines, right? And in the United States, stay assured that none of the agencies and none of the REI clinics, they can deviate the guideline. It's just how one chef has a recipe but make it more delicious than the other one. It's the expertise and experience, the way that the secret sauce works, the way that we make the protocol for each GC. A lot of clinics, they have a default program. You don't see the doctor. There is a third party team sit over there. They just send it to the doctor, and then you see the doctor at the day of the transfer. That's not going to happen. We have actually a welcoming day to the IP and to the GC. When after all these paperwork, legal, psych eval, agency matching process, we have an official meet and greet day in our clinic. I sit down in front of a GC and I sit down with the IP face to face and I go over the journey. So that is why Celanova. And why ACRC, I just mentioned from me as a clinic standpoint, it's a matter of being responsive, answering my email, being organized, and having experience with international. Because if you're going to be mad at agency, you're going to, be mad at me too. If you're going to be mad at me, you're going to rely on the agency. So we need to work as a team. And I think we already did a great collaboration to be able to offer the best service to you who are intended parents and RTCs.
Yeah, I completely, and I think like from my personal experience too, just with most like basically all IV fertilities clinics, like always the third party team and doctors are so responsive and like quick, within the day. We've definitely there's other aid clinics out there that aren't as responsive. So I highly recommend working with Celanova and IV fertility as your clinic. And yeah, I think that's, like you said, communication and having the balance between a strong third party, but also, the doctor being involved. Sometimes it can be like a lot of one or the other, like just the third party or just the doctor. But I think like Celanova has a great balance of, direct communication with Dr. Nassab, as well as a really strong third party team. And yeah, I think the collaboration so far has been, really good. And I'm also glad we're able to have meetings like this that are hopefully, helpful to intended parents as well. If you're watching this, you're already taking the first steps right into learning more about surrogacy, so that's great. And we're also, like both of us, are available for any questions or consultations as well. All right, so we do have a little, if there is any questions, I'm not sure. I don't see any questions that have come into the chat. Let me see here. Yeah, I don't personally see any questions. Um, let's see. Yeah, there's no open questions right now. Um, so if you guys do have, if anyone has any questions, you can just reach out to us personally and Dr. Nassab as well. And in these next 3 minutes too, if anyone has any questions, just feel free to put it in the chat. But thank you again, Dr. Nassab, for joining us today and sharing your expertise and insights. It's very helpful and also just, informative to me as well to hear from you. And thank you as well for everyone, who's here today. We hope that this discussion, that helps you better understand the gestational surrogacy journey and determining whether surrogacy is the right path for you and, what to expect throughout the process. So you can connect with ACRC. We do have the QR code on the screen. We also have our socials as well down below. Dr. Nassab, what is the best way for any intended parents to reach you and your team at?
Thank you so much for having me. I think that was a great conversation, and I think we highlighted so many common questions. Yes, as I said, the main office is in Rancho Santa Margarita in Southern California, and the surgery centers are in San Diego. You can reach out to us on our website, celanovafertility.com, or reach out to our Instagram, which is also Celanova Fertility. I have my own Instagram page, Susan Nassab, MD. I'm very hands-on answering the questions. I have also a social media marketing team behind me. They also answer my question. So if you need to find us, just Google our name and send a message.
Awesome. Well, thank you again, Dr. Nassab. It's lovely talking to you, and we truly appreciate your time. And we also hope whoever's watching to see you at a future ACRC global webinar. And yeah, that's it for now. Have a wonderful day, everyone. And thank you again, Dr. Nassab, for taking time today.
Thank you. Have a great day.
Yeah,
Bye.
take care. Bye.